Pillsbury, and this month we're joined by Dr. Weiner and Jennifer Sandack. They both work with me at Linden Oaks. They work in our substance use disorder treatment programs, and we want to talk with them about our new medication-assisted treatment program related to opioid use. So welcome both of you. Thank you for being here. I appreciate you taking the time to talk with us about medication-assisted treatment. Maybe before we get into that, though, I feel like we need to kind of lay the groundwork in terms of understanding just opioid use disorder in general and why it's such a big problem.
Mm-hmm. Yeah, so it's really a massive problem right now in the country. I think actually it was recently declared a state of emergency by President Trump, and even just here in Illinois, it's a big problem. So nationally, we're losing 91 people a day to opioid overdoses, just opioid overdoses.
It's astounding.
Yeah, it's huge. And in Illinois, I believe the number was just under 1,900 people last year who died from one of these overdoses. To put that number in context, that's more than 1.5 times the number of people who die from all gun-related crimes, and twice the number of people who die from all motor vehicle accidents in the state. So this is really a huge problem, and actually our health department is projecting that if we don't do anything about it, which we're doing, but if we didn't, that it would continue to grow by as much as, I believe, 30% over the next 3 years.
Wow.
So it's really a huge problem.
Wow. Does it kind of cross age groups as well, or does it tend to be focused on different age groups?
Yeah, well, it absolutely crosses age groups. You know, in terms of becoming addicted to an opioid like heroin or Norco, oxycodone, any of those sorts of pain-killing drugs, any age can become addicted to them. What we're seeing, though, predominantly, particularly with the folks who come in overdosing in our emergency departments, is we've got more of a younger cohort who's in their 20s generally, and they tend to be overdosing on heroin. Fentanyl also is becoming very big. Fentanyl is another synthetic opioid that's oftentimes mixed in with heroin. Carfentanil is even stronger than fentanyl, but we're seeing a lot more of that nationally, but also here in Illinois. You've got those younger folks, though, doing more of those. And then there's actually an older group as well, folks who are in their 60s and 70s, is what I'm seeing, at least from our emergency departments at Edward Hospital and Elmhurst Hospital, who are taking just high amounts of painkillers that are prescribed by physicians. And what'll happen is maybe they're having more pain that day, they take too much, or maybe they're having trouble sleeping and they go to a different doctor and they're prescribed a sleep aid or an anti-anxiety or something like that, and you combine those, and that contributes to the respiratory arrest. Okay.
So whereas with the younger population, it might be more the illegal substances transitioning from prescribed painkillers to more those illegal substances, the overdoses are in that area. With older populations, it's the prescribed medications, but oftentimes that overdose being triggered by multiple medications and the sort of combination of that.
Absolutely. The younger folks are a little more likely to be buying off the street, doing those sorts of things. The older folks, a little bit less likely to be doing that, but there's a lot of physicians, and I'm sure we'll talk about this soon, who don't necessarily know when they should be cutting somebody off, how high they should go. And they don't also necessarily look at the database we have in the state that lets people know, if you are a physician, you can see any prescription that someone picks up that's a controlled substance by looking at this database. Only 18% of physicians actually look at it. And so they don't necessarily know what somebody's taking. They put something else on top of that, and then someone goes into an overdose state.
Okay. So how did we get here? How did it get to be such a significant problem?
Yeah, no, it definitely built. So, and it's definitely a United States sort of thing. So the United States consumes 80% of the world's opioids, although we're 5% of the world's population. It's a huge issue. I think the statistic also is in 2012, enough opioids were dispensed for every adult in this country to have a bottle of pills.
I think I had heard that, which is like, you know, when you think of the number of people who aren't taking any medications, what that means for people who are taking those medications.
Right. It's astounding, and part of the issue is that things were messaged out very differently from two physicians by drug companies in the 90s. So there actually was a big lawsuit about this. Purdue Pharma had to pay a very large fine. When they came out with OxyContin, they were claiming that only 1% of people who use it would get addicted. They were claiming that we're under-medicating pain. They were part of the drive that made the American Medical Association make pain the fifth vital sign. And so there was all this talk about how we need to more pain control, more pain control, more pain control. Addiction is not an issue. They actually had 20,000 educational seminars over the course of 6 years for doctors trying to get them to prescribe more pain pills. And lo and behold, here we are. And so the prescribing actually really drives a lot of the issue and still has driven a lot of the issue. We've seen a lot of movement from national organizations to try to change physician habits, and it is working. Right now we're having to deal with what's already been set in motion though. And actually 80% of people who use heroin and fentanyl, they start with prescription pills first.
Okay. So it's a little bit like turning a battleship. It takes a long time to make those changes in terms of what doctors are used to in terms of prescribing patterns.
Yeah. Well, we call it an epidemic, and I think it's a really apt metaphor because when you're talking about an epidemic, you need to contain the outbreak, which is very much what we're doing in terms of prescribing habits, and then also supply control in terms of bringing heroin in from other countries and those sorts of things. And then you have to treat the afflicted. From an outbreak, right? And so there's a lot of people currently taking way too many for pain. People who are addicted to opioids, we need to treat them as well. And where we're at right now is we're trying to contain the outbreak in the new cases, and we're doing a pretty good job of starting to turn that tide. But there's so many people who are currently already on that track, and it's going to take a number of years to turn that ship.
Okay. So if someone has some kind of surgical procedure and is prescribed, an opioid pain medication, what are some guidelines for them to think about, or what do they need to keep in mind?
Yeah, absolutely. So this is a really tricky subject that I've actually talked with our surgeons a lot about. There's no necessarily one size fits all. For some surgical procedures, for example, full joint replacements, you need to have high range of motion right after surgery, so you need to be taking these opioids. For some, it's a lot less. Really, the most important thing someone can do, one, is talk to the physician about what they should expect in terms of pain control and what their taper is going to be. So they're really aware on the front end of when they should be on it, when they should be coming off of it. For more minor outpatient procedures, it's a lot less. You really don't need to be on it all the time. Another thing people should be aware of is that if they start to experience signs of physical dependency, which may happen if they've had a more intense procedure or they've been taking them for a while, that can be okay. That does not mean you have to hide it. Right? This is a normal process of taking something that's a habit-forming drug. You can still taper off. One of the biggest issues with these substances is people they become dependent, and then they feel like they need to hide it. Or they feel like they have to keep it to themselves instead of reaching out to their physician about it and saying, hey, I think this might be getting out of hand, or I'm concerned about this. They get worried about getting cut off or some consequence. So really sharing it. And the last thing I'd mention, I guess two things. Another common misconception, I wouldn't have thought this, you don't actually have to take them every 6 hours. A lot of people miss that as needed part. It's really just as much as needed for you to be able to function in the way that you need to function. Pain control does not mean complete pain nullification.
Right.
It means getting it down to a level that's acceptable. And lastly, dispose of the extra medication. A lot of physicians might give you way, way, way more than you need.
Sure.
It's really important that you dispose of it safely rather than keep it in your medicine cabinet where someone else, like say a child, could take it later.
Great. So a lot of great background information. When we come back from our break, I want to talk about the medication-assisted treatment program that has recently been started at Linden Oaks. So join us after the break to hear about that. Welcome back to Mental Health First Aid. We've been talking with Dr. Erin Weiner and Jennifer Sandack about the medication-assisted therapy programs at Linden Oaks. Dr. Weiner gave us a great explanation just about opioid use disorder overall, but I'd really like to transition into talking about medication-assisted therapy. So can you give us kind of an overview of what that's all about, the concept of it?
Sure. So medication-assisted treatment is an integrated approach to treating people who are struggling with substance use disorders. And it's really not different than what our medical counterparts have known for a long time. So for example, if you're treating a medical condition, it's very likely that you might be recommended to take some medicine, change your diet, have some exercise. It's just taken behavioral health a little bit longer to come mainstream with those types of approaches with regards to substance use disorders. So if we talk about medication-assisted therapy, what a person is going to be experiencing is a combination approach in which there will be some prescribing of some type of pharmaceutical that is appropriate for their type of substance use, as well as counseling and psychosocial support to help them on the path of recovery.
It sounds a little counterintuitive because, we were just talking about how it was maybe the overprescribing of a medication that causes the problem, and then to think about, okay, we're going to give you something else to help with this. So what is it that the medications that get prescribed in the medication-assisted therapy, what is it that they do that makes them an important part of the treatment?
Yeah, it's nice that you brought it up, the concept of this is counterintuitive, because for many years, I believe that the hallmark of addiction treatment was that the person takes nothing that is a chemical. And so this is like somewhat shocking to people that grew up in that type of education for addiction treatment. So what medication-assisted therapy does is it uses appropriate chemicals on a time-limited basis. And that's the appropriate way to go about this, is that these pharmaceuticals are a helper so that the person can best attend to and take advantage of psychotherapy. If you are still physiologically dependent and physiologically uncomfortable, it's going to be awfully hard to make your best use and best effort of counseling.
No, you want you to gut it out, right? Like that was kind of the old mantra of like somehow you had to like suffer through that withdrawal, that physiological withdrawal process. Yeah, I'm sorry, I interrupted you on that.
You're very correct in what you've said. And for example, with these pharmaceuticals or with heroin that's purchased off of the street, it has incredible impact on the human brain. And to ask a person who is physiologically dependent to just stop with no assistance and take advantage of counseling is really not an appropriate thing to ask of them. So we will use medications such as Suboxone, which is one of the chemicals that we use in the medication-assisted therapy clinic, to help people address the physical portion of the addiction process, while the counseling handles the emotional, behavioral, and the habits that they formed during the time that they were using drugs inappropriately.
Sure, and that whole idea of developing healthier social networks, healthier coping strategies, all of that. And it sounds like then what the medication does is help minimize that physiological process so you're able to do that other important work.
That's correct. So in our previous conversation, Dr. Weiner mentioned that sometimes the reason that people don't talk to their prescriber or any other physician about it is because they feel ashamed. And part of what medication-assisted therapy does in a clinic setting is they are in with other patients who are receiving the same medication for the same purpose, and there is a sense of community around it's okay to heal from this problem. I'm not the only one.
Great. So you mentioned Suboxone, but are there other medications that get used depending on the person or the substance that they're withdrawing from, or is that the primary medication that gets used?
So the answer is both.
Okay.
There are multiple pharmaceuticals that are used in medication-assisted treatment. Some of them are oral and have been around for quite some time. Some of them are more advanced and newer and are injectable. And multiple medications are available at the medication-assisted therapy clinic. It'll be a conversation between that patient and our prescriber about what is right for their situation.
Okay. All right. So it sounds like it's kind of a field that's really expanding at this point in terms of our learning what's going to work and what medications are helpful, all that kind of stuff. What does the research tell us about the helpfulness of medication-assisted treatment?
Yeah, well, the research is actually unequivocally positive. It's something where, again, sometimes people think it's counterintuitive. Is this actually a good thing to do? But what we know for a fact is that over and over again, we've seen that the substances that we use for this help people stay sober longer, not only just when they're using it, but then also when they're off. It helps them build those healthy habits. When they're taking these substances, they don't have those withdrawal symptoms. They don't have the cravings. The physiological part is gone. And also, another benefit is if they were to take an illicit substance, they wouldn't get high off of it.
Yeah.
So it really just knocks all of that out and lets them focus, as Jennifer was saying, on the process of healing other than just the biology. And so because you can really just put all of your focus onto those components and the biological is taken care of, what we've seen from a number of different studies is that people are more successful using medications than they are without using medications, particularly for opioid use.
Okay, but it is used for withdrawal from other substances as well.
Yeah, a lot of people don't know that there are FDA-approved substances for alcohol as well. The most common one that people have heard of is called antabuse. That's one actually that works on an enzyme about how you metabolize a component of alcohol and makes you very sick if you drink on it. But then there's also multiple medications, naltrexone, the injectable version of that's called Vivitrol, and then also Camprol that are useful in terms of curbing cravings for alcohol and making it less pleasurable when you drink, so it can lower risky drinking behaviors. It's less of a hard wall like the antabuse is. That one, when you take it, if you drink, you're going to be very uncomfortable and probably not want to do that again. The other ones are more if you're very motivated to do it anyway, it gives you a little nudge in that direction. But we've got some medications for alcohol as well, and there's some being researched for cannabis, but not there yet.
Okay, all right. Just having this conversation, I was thinking about, and we kind of alluded to it, how much our idea of substance use treatment has changed from 20 years ago, 30 years ago, which understanding it so much more as an illness and recognizing it as an illness instead of a moral failing on somebody's part. And I think this this just kind of solidifies our understanding of that much more.
Oh, very much so. I mean, we're calling it the disease of addiction right now for a reason. Maybe in the very, very beginning, you have a choice that then works on some genetic components as well, or some predispositions. But once you're actually in the throes of this, your brain literally fires differently. It gets rewired, and it's not just like making a choice. There's a lot of systems, biological, psychological, and social, that really holds you in place. And it is very much a disease, and just like any other disease, we want to use every tool in our arsenal in order to treat it.
And we want to respond to it that way, as a disease.
Very much so.
Yeah. So when we come back for our final segment, I'd like to really talk specifically about the medication-assisted treatment program at Linden Oaks. What could someone expect if they enrolled in that program? What does it kind of look like? So join us for our final segment when we hear about that.
Their support changed my life.
They were like family.
My voice is now heard.
A home for every animal.
My future is bright because they cared.
This is our home now. Thank you to the 1,200 nonprofits that serve Cass and Clay counties every day.
Welcome back to Mental Health First Aid. We've been talking with Dr. Erin Weiner and Jennifer Sandack about medication-assisted treatment for substance use disorder. But I'd really like to focus on the new medication-assisted treatment program at Linden Oaks. So, who would be appropriate for that clinic?
Yeah, so the people who are going to be appropriate for that clinic right now are folks who are right now who really identify as having a problem, either with prescription painkillers or if they're using drugs off the street. So anybody who is using heroin, anyone who's using fentanyl, certainly they'd be appropriate for this clinic. But even folks who are using prescription medications, if you're finding that you're going well over what you're prescribed, or you're going to multiple doctors, you're going to like the ED or urgent care or to dentists sometimes, or even just running out early because oftentimes you're going over and over, and maybe not just for pain. Maybe you're liking the way they make you feel, and that's why you're doing it.
So those are some good indicators or things that you could notice about yourself that might signal this is becoming a problem. This is impacting my life in a negative way.
Yeah, if it feels like it's getting really out of control. Even, I mean, certainly if you're buying street drugs, we could work with you on that. But even with the prescription ones, if it feels like it's not really in your control anymore, and you're doing behaviors to try to go around the system to get more, work with multiple people to get more, it's really preoccupying your mind a lot of the time. And again, not just about pain. A lot of people who take these do have pain. But for some, it stops being as much about just pain control and starts becoming a little bit about something else too. Not having withdrawal, keeping up with the amount they need to intake. So anyone who's experiencing those sorts of problems could be really good candidates to work with us.
Okay. And then, Jennifer, how would someone enroll in the MAT? Because that's what we're calling it, right? The MAT clinic. How would they enroll?
So the first step is a good, prudent assessment. And so we welcome anyone who finds themselves having any of the concerns that Dr. Weiner mentioned. And I wanted to add that this is not necessarily only for people who are struggling with physical pain. There are plenty of people who have had an emotional upset or something unexpected happen that was hurtful, and they come to find almost by accident that pain medication also helps them soothe or feel a sense of comfort from their emotional pain. So anyone who notices any type of that behavior in themselves, or certainly is purchasing heroin or other drugs illegally, we would welcome them to come to a free and confidential assessment at Linden Oaks in our assessment and referral center.
Okay.
And from there, we'll help them make a decision about what is the next step. For some people, the next step will be the MAT clinic. For others, there may be other issues that are uncovered. They may need some medical care or some other assistance. So the enrollment process will always start with that assessment, and then a professional will guide them on what's next.
Okay. So someone would start the enrollment process as if they were going to start some of the other programs at Linden Oaks as well, by kind of that, like you say, going through the assessment and referral center level of care assessment.
That's
kind
right.
of a thing. Okay. And you mentioned the assessment of the substance use piece and maybe the other sort of psychological things that are going on, but also a medical assessment is a part of that as well.
That's right. A person who undergoes that comprehensive free assessment will be asked a variety of questions that are around just what's happening in life right now, what's different than what it used to be, questions that are medical in nature, as well as some specific questions about what drugs are being used.
Okay. All right. So let's say someone then is enrolled in the program. What can they expect in terms of sort of like what's it going to be like to go to the clinic? How long am I going to be there? All that kind of stuff.
What we explain to folks is that we expect that most people who enroll in the clinic will be with us for about 6 months to 18 months, depending on their situation.
Okay.
Treatment is more intensive in the beginning. So when we start out with a relationship with each other, they'll be coming in weekly, and they should expect to be in the office with us about 2 hours each time that they visit us.
Okay.
If they enroll at the once a week for 4 weeks rate and are doing well at the end of that 4th week, we can have a conversation about whether it's time to go to every other week visits.
Okay.
And then after a few weeks of that, if stable at perhaps the 2nd month, we could have a conversation about whether we can move down to once a month. But that's going to be widely variable depending on how people are doing. There may be some individuals that come at the once a week rate for 6 or 8 weeks before they and their practitioner feel like it's time to come less often.
So that's actually less frequently people coming in than I would have anticipated. You know, when I think of some of our other outpatient programming, it's like on a daily basis, but you're saying this is a weekly basis to start out with, but for a couple of hours at a time.
That's
is what people
correct.
should expect.
So what people find is that for people that are able to make gains at the once a week rate, this is quite a bit less intrusive to their
Yes.
schedule and other commitments.
Yes. So what happens over the 2 hours that I would spend there?
Over the 2 hours that you're present in our clinic, you'll be seeing your prescriber, who is going to be talking to you about your actual prescription, talking to you about how you feel that that medication is assisting, whether you are getting the type of support from it that you were expecting. Based on those answers, we may be increasing a dose briefly, we may be decreasing a dose if it's time to have less. They'll also talk about side effects and ways to deal with anything that they might experience that is uncomfortable or just unusual, unexpected. The other time is spent in group psychotherapy with other adults who are also taking medication-assisted pharmaceuticals and having counselor-led group psychotherapy.
Okay. So most of it is group therapy as opposed to the discussion about the medication is kind of on an individual basis, but the counseling portion is more in a group setting.
That's correct. Our clients also do get individual case management with a practitioner who is a specialist in addiction medicine disorders. That does happen at the beginning about monthly. We could step down to quarterly as a person is doing better in their recovery.
Okay, all right. And you said like 6 months to maybe 18 months. So it's support over a long period of time, which can really be helpful to someone making that transition or navigating that change in their life.
That's right.
Okay, all right. To really be able to talk about all those things like maybe getting back to work or changing who I'm hanging out with, a lot of those kind of issues as well.
Yeah, it gives you time to not only talk about that, but also even just step down slowly. So when they get onto this medication, really ideally they're going to get off eventually, but we want to set them down very slowly so that they don't experience withdrawal. And so it's just a very gradual process, and if they're only coming in once a month anyway, it's just a very slow taper essentially, and we're not looking to rush folks off. In the beginning, there's a lot more foundational work that needs to be done in terms of being stable in recovery, and then as you get along in your treatment, it's more just about developing skills and slowly coming down off the medication.
Okay, so let me ask a tough question. What about insurance? Does insurance cover this kind of treatment?
So we accept in the clinic the same insurance that we take for everybody else at Linden Oaks. So insurance absolutely does cover the treatment.
Awesome, awesome. So we want to make sure that people have the contact information for both the Assessment Referral Center at Linden Oaks and then the MAT clinic. So how would someone schedule a level of care assessment?
It's exactly as you mentioned. They would call the Linden Oaks Assessment and Referral Center. The phone number to that is 630-305-5027. That can either be done by appointment, or if it's a situation where a family or someone feels that they need help right now, they can walk in to Linden Oaks Hospital.
Okay. And the number for the medication-assisted treatment clinic is?
That phone number is 630-646-8065. They're welcome to call if they would like general information or just to talk a little bit more in depth about the services in advance of having the appointment.
Great, great. Well, thank you both for being with me today and helping us understand this new kind of form of treatment for substance use disorder. Thank you for being with us, and until next month, be well.